Alright, okay. I know your in your timetable is obstructive nephropathy, right? It's used interchangeably with obstructive uropathy, but I rather use the term uropathy because it indicates urinary system. Nephropathy, terminology itself is just the kidney, but actually it's the whole urinary system which is involved. Yeah? So obstructive uropathy, nephropathy. Okay, this is what we will just look at. What is actually obstructive uropathy? What are the common causes, the pathogenesis, and the clinical significance of it. And a little bit on the morphology. We also look at the two main causes. Renal Colic, which is Urolithiasis, and Bph later on. Okay, just briefly, you have learned this, right? What is the urinary tract made up of? Thank God you have a pair of them, kidneys, ureter, which actually will contribute and drain into a bladder, and the bladder will pass out urine through the urethra, right? Okay. Okay, what is it? What is this obstructive uropathy? It's actually a disease or disorder that is due to blockage of flow of urine. Right. And as a result, it produce a backflow of urine and damage the kidney. Okay, that's what it is. Okay, and they can be either acute, sudden, or incidence of chronic. And because of the nature of the pathway, and you also have one pair, left and right ureter and kidney. It can be partial, it can be complete, it can be unilateral or bilateral, and the stimulus can be inside the urinary tract itself or from outside, compressing into the system. Yeah? So because it's a tract, so the level of obstruction can be anywhere from down there, urethra, bladder, ureter, and the kidney, especially the renal pelvis, right? Okay, so some of the causes are congenital anomalies are rare, but it does happen in newborn, in very small babies. Not commonly seen in clinical practice, but they do occur. So no, about urethral atresia, they're born with these abnormalities, which have to be corrected surgically ASAP, because otherwise it affect not just the kidney but the overall growth of the children, the babies. Posterior urethral valve, urethral strictures, all this PUJ obstruction, very, very rare. But just know that this lesions condition exists. The acquired ones are the more common ones seen in clinical practice, namely urinary colic. It means stone formation anywhere along the urinary tract. Also very, very common is benign prostatic hyperplasia. Right. Other causes include tumors. Could be tumors anywhere along the tract, prostate, bladder, ureter, even the kidney, or even adjacent organs or organs around there but outside the urinary tract. Not just tumors, inflammation also does cause, but to a much less situation. Very rare. Inflammation itself to cause obstruction, it can, but it's very rare. Of course, the extra or extrinsic cause like pregnancy, uterine polyps. Pregnancy I have not yet seen. Theoretically it does, but very, very rare. Uterine prolapse is more likely that's seen in gynae practice. Of course, there are another group of causes like functional disorders where patient can have spinal cord damage and the bladder is not functioning. So bladder will not functioning will accumulate urine, and that itself actually can cause some form of pseudo obstruction to the urinary tract. Okay, in brief, this picture shows somewhat a summary of what are the possible causes. For example, you have a stenosis, congenital stenosis at this pelvic junction, or obstruction by a stone, physical obstruction, stone. or calculi. Tumors also, blood clot, rare but can happen. Sometimes inflammation, also very rare, inflammation or just stenosis of ureter, rarely seen. More common are the stone at the pelvic calyceal region or stone within the ureter. This is external compression by pregnancy and enlarged uterus for other reasons. All right. The other thing top here is congenial stenosis here at the top of the ureter. Okay. Or loop. So loop is also very rare, but these are some of the congenital situation or lesion. They can cause obstruction. Lower down, bladder cancer. But very rarely it produce obstruction because usually the cancer itself does not is quite high morbidity. Yeah? They don't have time yet actually to produce, but patient actually present with other complication or other symptoms of the bladder cancer itself. But sometimes it does. Lower down, this is important. The prostate. Very, very common prostatic hyperplasia causing obstruction. It obstructs here, lower down at the bladder neck, right? Less common prostatic carcinoma. The benign prostatic hyperplasia are the more common clinical scenario. Okay, lower down, these are the congenital lesion in children, posterior urethral valve, stenosis, or stricture, meatal stenosis, phimosis, right? This is not commonly seen unless you are a practicing pediatric surgeon, that you do these cases more often compared to other people, but overall it's not that common. Okay, what is the pathophysiological effects? Okay, because there's obstruction, and the obstruction can be one side, both side, can be complete, incomplete. So because of the effects can be very variable, all right, depending on the severity and extent of the lesion. Because of the obstruction, things just become static. So that leads to stasis of urine. That itself actually predisposed to risk of infection and stone. And along the way, because of the injury, actually inflammation of the kidney is being provoked, right? Okay, because of the collection of urine that cannot come out, that produce progressive dilatation of the renal system. Eventually, there's progressive atrophy because of the pressure of the dilatation. Right, so this is what happened even when there is obstruction, but because it's not complete, most of the time it's not complete. So glomerular filtration still ongoing, still go on, and there's still urine being produced, but they're not completely voided. So this goes on for some time, especially those cases which are gradual and insidious. They grow slowly over time. So the collection of urine will cause a progressive dilatation. The urine got collected there, is stagnant, it cannot move. So that causes dilatation of the pelvic calyceal system, and in turn it created high pressure in the pelvis, which is will get transmitted backwards to the collecting ducts within the cortical areas. And this itself will cause renal atrophy, the intense pressure. Not just the kidney parenchyma that is being compressed, it also compresses the blood vessels. You know, your kidney is very well vascularized for it to resume its function. So all the blood vessels, the supply, arterial, venous, will be compressed, and that will lead to reduction of blood flow. Disruption of the blood flow will impair the tubule function, which is to concentrate urine. So there'll be inability to concentrate the urine, and later at the end you can it can lead to reduced GFR. Right? No urine is being produced. So as I said, along the way, all this provocation, as to mention, leads to inflammation of the renal parenchyma, which leads to inflammatory process become chronic, and you end up with a lot of fibrosis and also tubular and glomerular destruction or atrophy. Right, okay, theoretically, this is theoretical. Maybe you should do a study, how long or an obstruction will cause permanent damage. 3 weeks complete obstruction, if you don't treat, you end up with a total kidney damage, irreversible, right? Whereas if it's not complete, it tends to be more gradual and chronic. Maybe it takes up longer, for example, 3 months. In practice, it's not just easy to say 3 weeks or 3 months, but because there's so many other factors affecting the dysfunction of the kidney. But if you don't treat this condition early, you get at the end you get a damaged kidney, irreversible. Yeah, right. Okay, this flow chart short or summarize the functional and structural damage. Yeah? Okay, whenever there's obstruction, when it is very severe and sudden, it leads to abrupt fall in J5. That's why you get acute kidney injury, right? But more often is more chronic. Yeah. So all this mechanical stimulation, because of the dilatation, the pressure, it will stimulate all the intrinsic renal cell. There's generation of all this angiotensin too. All right, and that alter the whole dynamic of the kidney. So you don't interfere at this point, you get kidney injury. Same time, other processes that takes place are all this inflammation. Acute inflammation, chronic inflammation, macrophage, lymphocytes involving your TNF and all the free radicals. So that will lead to all these changes, myofibroblast accumulation, fibrosis, tubular injury, atrophy, ischemia. At the end, you get nephron loss, and that will be when it is severe, you get irreversible renal injury. You get chronic kidney disease with a lot of fibrosis and scarring. So the function will be badly affected by this time, right? Okay, so just to summarize, as a result of those pathophysiology, these are the complications that can arise in your patients if you don't treat them enough or you don't interfere early. Okay, the patient will be susceptible to infection, right? Infection of the kidney is pyelonephritis. Of course, you can get infection of the bladder as well as cystitis. The other important complication is stone formation, which is urolithiasis. Urolithiasis. Uro is urinary tract. Lithiasis is stone. Stone formation. The other word for it is calculi. Calculi is the stone. Urolithiasis is the process. Okay. So as I said earlier, when all these are not relieved, you can get a permanent renal atrophy, right? Injury and damage, right? These are the things that I explained from the picture just now. You can get acute episodes of chronic sweat. Sometimes when the obstruction is severe, you can get like total urinary retention, like obstruction at the prostate. Let's say, patient is not treated for the BPH. It gradually actually causing obstruction without any symptom, and suddenly complete obstruction takes place. That's when the patient cannot pass out at all, and the bladder will contain a large amount of urine. That is a very, very painful condition. Such patient you have to bring to the casualty and immediately puncture in and put in a tube, suprapubic, or you put in through the urethra, which usually not possible because of the enlarged prostate. You have to relieve. This is a very, very painful, uncomfortable situation. Patient is in a lot of pain. The other chronic retention, more gradual, not as acute. That can lead to overflow urinary incontinence. The bladder is full, but for some reason patient cannot evacuate normally, right? So it will sometimes trigger when they cough, the urine comes out. So that's what we call overflow urinary incontinence. But of course, at the end, this is a last complication that we want to avoid in such patient. These conditions are treatable. So recognition of diagnosis at early stage is very, very important. Whenever your patient comes to you with urinary complaint, don't take it lightly, especially when they're elderly, men especially. Look out for prostate enlargement. Okay. Okay, clinical features. Clinical features of BPH, it depends on actually where is the site, the location of the obstruction, the severity, bilateral, unilateral. But the main change would be the urinary habit, because that's the function of your kidney. Patient complain to you like, doctor, I go out so frequently, to the toilet, but I pass very little amount, right? That's frequency, and they frequently have the urge, but very little comes out, right? And incontinence, as I explained just now, sometimes when there's overflow, a lot of urine, but difficult to pass out, they have incontinence, right? Nocturia is frequently going to the toilet at night more than normal. Dysuria is painful of passing out urine. This has usually is associated with stone, calculi. Of course, when chronic, sometimes the bladder become hypertrophic as well, and they are not cannot function normally. So patients sometimes have feeling of incomplete emptying of the bladder. They've gone. They thought, they feel that they could have voided all, but they feel it still cannot. Some amount of urine cannot be passed out. So feeling of incomplete emptying of bladder. Yeah. Of course, because of the fluctuation of or disruption of your glomerular and kidney function, there could be an alternating episode of increased urine output or decreased urine output because of the alternating GFR, depending on the severity of the process at that point in time. Before finally they come up with renal failure. When kidney has failed, you don't have any urine at all. There is oligouria, right? Okay, the other features could be pain. This is when there's acute obstruction, distension of the collecting system in the kidney. It can cause acute pain. When it's more of chronic ones, which is more common, actually the pain is not as intense. It's more like vague flank pain. Flank is the part of your abdomen posteriorly. Right. Of course, symptoms of sign and symptoms of possible underlying cause, renal calculi, renal colic, a very painful condition. Very, very painful. They describe that next to delivering a baby, labor pain, renal colic is next painful condition. Right. I don't know. I have not the experience of passing out stone or renal calculi, but of course I have delivered. Those who have delivered will swear, right? It is very painful. You can't describe how painful it is to deliver a baby. But I've seen patients who had renal colic. I've got strong family history. My brothers all had this, and my son, my eldest, has been diagnosed with also renal calculi. In fact, actually, all my uncles on my father's side had renal calculi. So it tends to be. We talk about renal calculi later on. It tends to be in the family, familial or hereditary for some reason. So you can have features of those underlying or associated causes. Renal calculi, bladder syndrome due to BPH. BPH is benign prostatic hyperplasia. Is everyone okay? Am I too fast?
No, it's okay, doctor.
Okay. This is actually very short lecture, very straightforward. Actually earlier there was construction work next door, it was very noisy, so suddenly I was worried that I can't talk to you all, but now suddenly it's quiet, so I hope they don't come back. All right, okay, what about the clinicals? What is actually like the outcome of this disorder? It depends, the involvement of the affected urinary system. The unilateral tends to be asymptomatic because remember I said you have pairs of kidneys, ureter and all that. So when it's unilateral, it can be silent, especially when it's partial. And good prognosis with this condition, because you treat early, the condition is reversible. Even though you have already some effect in the kidney, it is still reversible, right? When it's bilateral, it can be partial or complete obstruction. When it's partial and there's inability to concentrate urine, this is when you get polyuria or nocturia. Polyuria is a lot frequent and a lot of urine passed out. And nocturia is because there's a lot of urine they have. What is that sound? Hello? Hello? Hello?
Yes, doctor.
Yes, bro.
You can hear me?
Yeah, we
Yeah.
can.
Oh, so that's not from my computer.
Yeah, I think not.
No.
Was I okay? Was I interrupted just now? Okay.
I think maybe someone accidentally opened them.
Yeah.
Oh, so my sound system okay lah, right? Okay. Okay. We're talking about bilateral obstruction. Can be partial, can be complete. Yeah, bilateral can present with polyuria, nocturia, because of inability to concentrate. So the urine is very dilute and voluminous. So you have a lot of urine piping passing out, and that's called polyuria. Frequency increase with amount also increase, and because of that, if they wake you up at night, so that's the term nocturia, right? And sometimes patient present with hypertension because stimulation of all those angiotensin system. Bilateral, okay, this is not this is not good when it's bilateral and complete. This is when very soon patient will develop oliguria and anuria, and this you have to treat urgently, because if you don't treat, they don't survive. It's incompatible because they can lead to injury to both sides of the kidney. Okay, morphologically, just introduction of these terms. You will hear hydronephrotic kidney, hydroureter. What does it mean? Hydronephrosis is when the pelvic calcium system is grossly dilated, because of the pressure created by the urine being produced but not being passed out. Okay, so similarly, it goes down, it creates dilatation of the ureter. You call it hydroureter. So the obstruction tend to be unilateral when obstruction is at the ureter and above. That means it's only involved that side, unless it involve both ureter. It can be bilateral obstruction to the kidney when the obstruction is below the ureter, like for example in the bladder itself, or at the base of the bladder where you have the prostate and the prostate is enlarged. So that can produce bilateral hydronephrosis or bilateral pathology in both kidneys. Right. Okay. Morphologically, when you have a patient, let's say they have this disorder, and for some reason the surgeon have to remove the kidney, what you see is actually the kidneys are enlarged, either very slight or massive, depending on the severity and duration of the insult. Okay, you see obvious dilatation of pelvic calcium system, and the compression into the renal parenchyma lead to thinning of the cortex. So much so sometimes they look cystic. They just dilated and the parenchyma is atrophied or reduced. So they look like a very thin wall tissue, like a cyst almost. Okay. Of course, dilatation ureter can be observed as well. Microscopically is what you see as a result of those pathogenesis that I have explained just now. It leads to inflammation, so it can lead to reparative process, which is fibrosis. So you can see inflammation, you see fibrosis, collagen laying down, and the compression effect itself that cause atrophy of parenchyma leads to tubular atrophy microscopically. So the tubules will be abnormal, dilated, but the cells are compressed. They look atrophied. I show you picture in a while. Okay, diagrammatically, alright, this bladder is normal. Okay, normal is renal pelvis, and this is the kidney, this is the medulla, this is cortex. Remember, you have learned all this, right, in normal anatomy histology, right?
Yes, ma'am.
Okay, so this is what happened when it's obstructed. The ureter is dilated. The ureter, what is the ureter diameter of ureter? Normal.
Because of the congestion of urine inside the ureter and the pelvis.
No, I asked the normal size of ureter diameter. The lumen of ureter, what is the size?
Is it 6 to 8 millimeter?
6 to?
8 millimeter.
I don't know. You tell me. You ada belajar kan? You sure? It's very small actually, right? But it's actually very distensible. It follows the amount of urine that comes out. It's very small. So with obstructive causes, they gets dilated grossly. So it can start from here, ureter, up to the pelvic calcium system. Another diagram to illustrate to you, right? When you have like obstruction at the pelvic ureteric junction, this is a congenital anomaly. You can have stenosis here. So this part will be obstructed. will be dilated and cause hydronephrosis. Okay, if you have uretero-vesical junction stenosis or atresia or obstruction, then the dilated part will start from here, the ureter up to pelvic calyceus system. So hydroureter will start here. This one is when you have more bilateral involvement. The obstruction is usually lower down. Posterior urethral valve abnormalities, atresia or stenosis, or any bladder neck obstruction due to prostatic enlargement, benign or malignant, more often benign, right? Or you have diverticular of the bladder, right? Sorry. This will lead to obstruction starting from here and upwards. You have thickened bladder wall, you have hydroureter, you have hydronephrosis. So this more localized. These are more severe, more extensive involvement if the obstruction is lower down. I hope you can make this out. Yeah, right. Okay. Now this is what we will see. Gross. This is a gross normal kidney. Look here. You see the medulla. You see medulla and cortex. Fibrotic calyceus system here. But look here. You can't actually make out the whole pelvic calyceus system here, the collecting final collecting system here is all dilated, and there's actually stones here, right? Formation of stones. This is a grossly dilated. But right, when you cut, you see solid tissue. Like here, it's like a space. There's no tissue here. It's just compressed tissue, very thin. This is the what remains of the medulla, right? These have got good comparison because now you see the normal part of the kidney, right? This is a one kidney which is open like a book, So this is symmetrical. It's cut partially to expose the abnormal areas. This is the normal kidney, and this part is actually hydronephrotic, dilated, like cystic spaces, like spaces. So like empty spaces, right? And these are the thin, the compressed part outside. Okay. This is an example where there's congenital obstruction here, lower down at the urethral orifice, and this is the ureter, which is dilated. A normal ureter is very thin. That's why I asked you what is the size. It's very small, just a strip of tissue when you cut open. But this one is really expanded. Not just that part of this. Okay, this is part of the pelvic calyceus system which is dilated, and there's a stone here. Can you see that? There's calculi there actually. This is part of the remaining normal kidney, but of course here is compressed. A bit of the normal part is here. Right, so this is a hydronephrotic and hydrouretic kidney urinary system. Okay, histologically this is what we can see. You remember your normal histology of the kidney, you have your nephron, the glomeruli, the basic functional unit, and around it you have all these tubules. What is PCT? What is DCT?
Distal.
They're quite different looking, but they are normal. These are the proximal, these are the distal collecting tubules. So in patients with the abnormal kidneys I showed you just now, you take a section and look at it under microscope, this is what you can expect to see. You see there's all these tubules are many, they are packed back to back. They just closely packed to each other. Tubules. But in this case, there is a lot of inflammation. Can you see these tubules? Can you?
Yes, doctor.
They're quite normal. They're still there. They're not, they still resemble normal ones. But look here. What happened here?
A lot of inflammation.
Yeah, inflammation.
White
It
blood
has
cells.
replaced. Yeah, it has actually replaced and destroyed. Okay. Also this part there's a lot of inflammation, and you hardly see any tubules here. What is this?
That's a glomerulus.
Yeah, it's a glomerulus. What is this? What is this? This and this. Any idea?
Sclerotic fibrotic tissue.
They are actually a tissue which has undergone chronic inflammation, has gone into reparative or fibrotic.
Fibrosis.
Yeah, fibrotic. There's a lot of collagen in it. This is actually originally glomerulus. They are scarred already. They have been inflamed. They are inflamed. They have been replaced by fibrosis. So this is sclerotic glomeruli damage. So all in all, you see damage both to the collecting tubules and the glomeruli. This is another feature which is actually characteristic due to chronic inflammation, chronic pyelonephritis. Again, you see all this lymphocyte, chronic inflammation. You see tubules, but they're not normal. Can I show you some? Maybe this is still like fairly normal tubules. This one like dying. And these are the rest of tubules. They're not normal. Can you appreciate that? Why did I say it's not normal?
Because of the pink color colloid-like material, is it?
Yeah, they contain something. What do you think they contain?
Blood,
Not really.
thyroid hormone.
Hmm?
It's thyroidization.
It's not thyroid. They resemble thyroid acini. That's why pathologically we call it thyroidization of the tubules like here. But basically they are actually atrophied. They atrophied. If only I can zoom high power. This is one tubule. The lining of the epithelium is no more. And just now you see? Sorry. How nice these tubular lining cells?
From cuboidal to squamous.
Yes, they're very nice and very pretty looking. What about here? Can you see the lining?
No.
Difficult to see. It is there, but it's very atrophied. They're very small. They have diminished in size. They are atrophied similarly. So this is atrophic tubules of the urinary system. So this is basically all due to chronic inflammation. So this some of the things, some of the microscopy that you can see in a patient that has undergone hydronephrosis because of the other the inflammation that comes with it. Right? There's one glomeruli fairly intact here. Okay, that's about it. So just appreciate all this morphology, chronic inflammation. Okay, we are done. We are done with the obstructive uropathy. So next is we're going to look at the most common cause of obstructive uropathy, which is urolithiasis. That refers to urinary calculi, which actually can take place at any level, from the bladder up to the kidney. But most common site are the kidney, right? Somehow, male is more frequently affected. I just told you, all my uncles, my father and my uncles has got this, but not my aunties. They are spared, and my brothers, my three brothers, all had this, but all of us, the three girls, are not affected. Don't ask me why. I don't know, and we don't know. Nobody knows. Somehow there's a predilection for female sex. So you guys be careful, and those who are fasting, right? Take extra effort to drink a lot of water when you break your fast. My son had his first attack last year on the first day of Hari Raya. So it's actually precipitated by the fasting state because we consume less fluid, less water during fasting month. So when you break your fast, compensate, drink as much as you can, right? To flush out your kidney. Don't get your kidney dehydrated, right? Okay, so it is common among youngish age group, 20 to 30s or 30s to 40s. Rarely we get it in children or very, very old, usually at this age. As I said, it tend to be familial, or maybe there's hereditary predisposition to it. We don't know. These are some underlying condition. Gout is fairly common. Gout is when you have increase in uric acid. But all these more congenital lesion, which is not common, right? Okay. So how do you get stones in the kidney? Usually it's not as straightforward as how I listed here. Sometimes you don't find these features, you can't document or say yes, this patient had evidence of extra amount of this or that, so quite often that we cannot explain, but some of these explanation are found in patient. So basically it's super saturation. Your urine passes out a lot of electrolytes and minerals and all that. So what happens is sometimes super saturation, I think you all learned in chemistry before, right? When you have a solute and solution, is it? No, I can't remember. So the solute have to be a certain amount. Excess of that, then you cannot make it soluble anymore. It cannot dissolve in the solution. So that is what supersaturation means. Increase in the amount of that particular stone in the urine that exceed the solubility, right? Okay, this is low urine volume. This is what I just described. It's more common during fasting month, because people take less amount of water and lower urine volume than normal. Of course, there are other factors like changes in urine pH, like when you can have this stone precipitate in alkaline urine. Alkaline urine is basically predisposed in infection, UTI, urinary infection, and in uric acid. People with uric acid stones, they somehow has got tendency to produce acid urine. We don't know why. They have tendency to produce more acid urine compared to other people. Of course, other factors are presence of bacteria. Bacteria itself, when they're not treated well, they don't clear up. They provide like a nidus, a focus of where undissolved minerals can set up on top of the bacterial focus. Deficient Hematitis disease is not common, but of course, as I said, majority we cannot explain. We call it idiopathic. In medicine, when you don't know the cause, you call it idiopathic. You know not?
Yes.
Throughout your career later on, there are a lot of disorders that you can't explain. You call it idiopathic. Sounds like idiot to me, but it's not that we are idiot, It's not that in this world you can't explain all illnesses or all disorders. We are yet to study or outline many diseases that affect us human beings. We can't explain everything. So for the moment, until we can clarify why disease such disease comes up and affect you, we call it idiopathic. All right. Okay, just to illustrate to you the common types of disease, study of chemical components. Four main types of stones or calculi. Most common is the calcium. It's usually a combination of calcium oxalate or calcium oxalate plus phosphate. Right? It is associated with hypercalcemia, with or without hypercalciuria, but quite a big majority of patients actually have hypercalciuria without hypercalcemia, and we cannot explain that. So that's why you had the term here, idiopathic. So somehow the nature of the minerals are that they form small hard stones. So that tend to damage the urethral mucosa when it's passed down from the kidney downwards. When you have a big stone in the kidney, they don't break down. It doesn't cause you pain. It doesn't cause much problem because it gradually cause effect in the dilatation, all that. So patients are usually asymptomatic when the stones are very big. It's just when the stones break up for some reason into tiny parts and they start to go down the ureter. That's why I asked you the size of ureter. Ureter is actually very small. And these stones, when they break out, they might be tiny, 0.545 centimeter, but they're irregular with jagged edges. So they go down, they obstruct, they damage your That's when actually patient can come to you with very, very painful complain of pain in the flank, very, very severe, and they will just be rolling about and nothing can stop the pain until they come, and sometimes one painkiller does not work. You have to give like 2-3 painkillers for it to stop. It's a very painful condition, and you can only stop the pain when the calculi goes down and be excreted out, right? Okay, the other type of stone is triple stone, and this actually is associated with infection, especially when the implicated organism Proteus convert urea to ammonia, and that makes the urine alkali, which favors the precipitation of magnesium ammonium phosphate salt, right? So that's why we call it triple stone. This one tends to be big, okay, and it can be big that it gives rise to, oh, I don't have a picture. Do I have a picture? It follows it conforms to the structure of the pelvic calyceal system in such a way they look like staghorn. You know what is a staghorn? Is the, what is that animal? That the horn are like macam, I forgot to put picture lah. So sorry. Anyway, look up staghorn calculi. It's quite nice to look at, can keep in the museum if you have one. It's very common, very common. In fact, if you x-ray the patient, you can see the calculi. Okay, the other two types, uric acid is, this one must be careful. When you x-ray a patient, you don't see the stone, you don't exclude yet a urinary calculi, because uric acid stone is radiolucent. You cannot capture them on plain x-ray. This is associated with increased level of uric acid. This is well known in patients with gout. Okay, gouty arthritis, they have limited ability to break down uric acid. So when they have eaten food high in uric acid or protein, the level will go up. So they tend to have gouty arthritis. At the same time, they can have development of the stone in the kidney. The other condition is patient with leukemia who have very high rapid cell turnover. This is not common because usually symptoms is due to leukemia itself. So formation of stone are gradual and takes time, so you rarely see. Right? Yeah. In this patient, actually, why they have this pathology is in people who don't have this tendency of acidic urine, like you and me, we can adjust our urine pH. But this kind of people, they have more tendency to have acidic urine for some reason. We don't know why. pH is usually less than 5.5. So that promotes the formation, precipitation of uric acid. Clinical features, okay, usually they tend to be one-sided. Thank God you have another kidney to compensate if this particular kidney is affected by the renal calculi. Majority of patients are one-sided. Okay, this is the most affected part, pelvic region. The stones can be multiple. I showed you a picture just now, right? It can be just like at the pelvis a bit, and then a bit extended inwards into the medullary region, so frequently there are multiple, so this is what can happen that can rise to the clinical features, and when they ulcerate, they can injure the mucosa, so they cause bleeding, so that the patient can complain, "Doctor, I passed out dark red colored urine, bleeding." It means that it's bleeding in the urine, there's blood in the urine. So the most common cause of hematuria, blood in the urine, is renal calculi. Of course, when it's obstructed, that's when it causes very intense pain. That's when they travel down the ureter. As long as they're in the kidney, no pain. Not to say they're safe, but they don't experience the pain. Once it's broken down, that's when you have this. Okay, when they don't break down, this is when they are silent, no symptom. But of course, other clinical features include some symptom infection when it's complicated. This is a stone. Not really staghorn. Staghorn is when actually this one is continuous. Can you see this is a kidney? Right? These are the stones formed inside the kidney. Here. So sometimes when imagine this is continuous, this stone from the top of the ureter continuous with all this, like that, shape like that. This already like broken lah. Okay. It appears like a stacked horn. Like the horn of a deer. You know deer? D-E-E-R, deer. The animal in the forest. So the horn is, the horn is like branching. That's the word I want to say. They're branching. So actually the stone can branch conforming the structure of your kidney like that, you know. So that's why we call it stacked horn calculi. That can be easily detected by X-rays. Where are we? Right. Okay. So how do you diagnose? For radio opaque calculi, easily pick up by plain X-ray. But remember the uric acid, calculi acid, which cannot be detected by plain X-ray. And then you have to find other means, like maybe ultrasound, or sometimes you do this intravenous urogram. This is only done by radiologists. Of course, you do also other serum study like serum uric acid or urinary, looking at urinary cast, you know. But not all urine that has got crystal means the patient has got calculi. You have to look and correlate at the overall investigation. Alright. Okay, that's urinary calculi. Okay, now we will look at the other common cause of urinary obstruction, which is BPH. Again, this is very, very, very common affecting men. It's just that they are very slow growing, they are indolent, they don't really grow very big. So majority actually of patients are asymptomatic. It's only a certain percentage that actually grows quite big to really obstruct the urethra at the base of the bladder. So it said that 90% of people who, if they reach 80 years old, majority will have been affected by BPH. So because of the majority asymptomatic cases doesn't come to you, so only like a small percentage that come to you for treatment. Because we don't know. We don't know. We suspect that it could be due hormonal testosterone influence, but we're really not sure. So what happens actually, the basic pathology is the hormonal influence thought of is stimulating the glands and the stroma in the normal prostate to be proliferating excessively. You have learned about this, I think, earlier in your neoplasm, your general pathology. I just taught the students here is this. So an example of benign tumors, okay, due to proliferation of both stroma and epithelium, which are the glands, right? So when it's enlarged, when it's growing, it will enlarge the glands. So when they're large enough, they can compress urethra and block the flow of your urinary flow. Okay, symptoms-wise, as it affects the outflow of your normal urine, this is what you can come with. The patient come with frequency, nocturia, dysuria, poor stream, dribbling, right? And sometimes, I've seen patient who comes with this, acute urinary retention, bladder distended, abdomen hugely distended, comes to you, very painful in a, let's say, 50, 60-year-old man. Okay, you relieve the urine, you let the urine out, then you start to check on the patient. By simple, actually, per rectal examination, you can feel the prostate. Usually, if that's the cause, it can be palpated and the prostate is enlarged, right? Okay, other clinical features can be due to infection because of the chronic urinary stasis, meaning that they cannot urinate completely out. So some residual urine is present, and that can actually cause stasis of urine, which is a fertile soil for infection to set in, bacterial infection. Of course, as we said just now, it can cause hydronephrosis and compensatory bladder hypertrophy. Oh, remember, BPH is a benign prostatic tumor. It does not transform into malignancy. So it's not associated with future development of cancer of prostate. All right. Okay, I think we've come to the end of lecture actually, because I will not elaborate on this because this comes in the next topic, neoplasm of urinary tract. But this can be part of causes of hydronephrosis or obstructive uropathy. These are within the urinary tract system. These are intrinsic, retroperitoneal tumors or carcinoma uterine cervix. All that. Alright. Again, inflammation is not common cause, but it does cause obstructive. Yeah, we've come to the end. Actually, these are just some pictures to show you. I'm sure you've seen this in your earlier pathology blog. Benign prostatic hyperplasia, grossly circumscribed because it's benign, a nice border, but cut section shows nodularity. This because of the excessive proliferation of stroma as well as the glands. This is the microscopy or histology, abundant stroma in the background, and the glands are just proliferating. The lining is hyperplastic, multiple layer. I hope you remember how this looks like compared to normal. Hello class, are you there?
Yes, we're here.
This is just this is a bladder cut line causing bladder obstruction and hypertrophy. All right, yeah, we are done. Thank you very much.
Prof.
Okay. Straightforward, right? So this should be good for you. Perhaps you had quite a heavy week so far. Did you? You had?
Yeah.
Today is Thursday. Tomorrow is Friday. Actually, my lecture is supposed to be tomorrow, but tomorrow is general pathology exams. So you all should be free tomorrow, is it?
Yeah.
Yes.
Oh, that's good. Have time to study and have a good weekend.
You too, doctor.
Okay, guys and girls. Is that okay?
Thank you, doctor.
Prof.
Call it. Yeah.
For the kidney stone, when it break down, is it possible that it obstruct the urethra?
Yes, it can. It can be
Oh.
passed down from ureter. Despite all the pain, sometimes it can be passed down. Of course, with medication, is very difficult for it to come down itself. So, the doctors will prescribe you muscle relaxant so that the ureter can dilate. At the same time, they give medication which can sort of dissolve. Sometimes it works, sometimes it doesn't. So they can be broken down further, and sometimes it's passed out unnoticed. But there are times that it get passed down to the bladder and get stuck to the urethra. So that's another painful episode. But somehow, if you treat them early, they can get avoided unnoticed. So incident that they go stuck at the urethra is less common. Right? It can happen, but not that common. Alright,
Oh.
do I answer your question?
Yes. But if it's happen, can it be treated by insertion of urine catheter?
Excision?
Insertion
Insertion of?
catheter.
Oh, theoretically you can, but I don't think the patient can take it. It's going to be very, very painful. So the other alternative is if the surgeon or the treating doctor don't give all this medication to dilate and break down the stone, sometimes treatment they get a bit more aggressive, because for immediate relief they will do laser therapy, laser treatment, which means you need to open up a bit and target the stone to break it up. But it's a very expensive procedure, fairly invasive. So if you get it done in private, it costs you like 20,000-30,000. Like in government, it's much cheaper. So usually we treat it at that stage itself. Back to your question, what was your question just now?
Oh, sorry, for the
To
urine
insert.
catheter.
So usually we don't or we avoid putting in catheter. It's going to be very painful if you have to do that. So we avoid that. And actually, occasion where they stuck at the ureter is not that common. So more often is in the kidney. So kidney treatment is by medical. You give medication or you go in. It's a bit invasive, but you laser destroy the stone for it to come out, right? So to your question whether you put insert a catheter, we will not put. I don't think the patient can stand the pain. It's going to be very painful. And what you're going to do, you put in the catheter, you might push the stone back into the bladder. You cannot take it out that way actually. You can't. Alright?
Alright. And for a person with renal failure and need to undergo dialysis, does it mean that person cannot completely cannot excrete urine?
You're talking about okay, rephrase the question again. Renal failure.
Yeah, a person have renal failure and is undergoing dialysis. Does it mean that he cannot completely excrete any urine? Cannot do any voiding?
When you do dialysis, the job of the kidney is taken over by the machine. So there's no question like they produce urine or not, you know, at that point. So we dialyze the patient until we see the renal function back to normal. Then you take out the machine, then you allow the patient to have normal voiding or normal urine production. Okay? You're talking about whether the kidney is able to. I suppose it can, but usually the dialysis machine will take over the job of the kidney. So I'm not a nephrologist. Let me see. Your question is whether they in terms of function, they slowly will recover depending. Let's say is due to hypovolemic shock. No, once you correct that hypovolemia, whatever damage to the kidney, we will reversible. So whereas you dialyze the patient, the kidney will recover and started to produce their own urine because they're resuming their normal function. Is that what your question is?
Sorry. What do you mean, doctor?
No, you do dialysis. Why? Why you do dialysis?
Because the urine cannot function.
Right?
Yeah, the kidney cannot function.
Okay, and the kidney cannot function can be many causes, right?
Yes.
Hypovolemia, no, anemia or whatever. So as you dialyze the patient, the machine take over the job of the kidney. Whether the kidney can start to produce their own urine, that's your question, right?
Yeah.
It depends on the cause. Depends on the cause. Let's say the cause is hypovolemia due to bleeding. If you correct that, then they will recover, turns back normal. If it's caused by severe infection, you treat the infection, they can recover. So once they recover, you stop the dialysis. But in patient when the in kidney are permanently damaged, you know, no matter what cause, and they are like both sides already atrophied, and with chronic fibrosis and all that, no more renal function. This is I think you learned this morning, chronic renal failure, right? That's when this patient cannot recover. So dialysis have to be lifetime procedure for them, because you have to have the machine to take over the job of the kidney, which is totally gone. Do I answer you correctly?
Yeah, I understand that the dialysis will take over the kidney function.
Yes.
So it means that when the kidney is failing, it will not produce any urine.
If the cause is removed and they are recovering, the kidney recovering, they will start to produce their own urine.
Yeah.
Then you stop the dialysis. But in patient where the kidney, especially bilateral, is affected and damaged, then they cannot function anymore. They will not produce any more urine. Then dialysis become permanent. This is what happens with patients with CKD, chronic kidney disease, where they go for dialysis every other day, 3 times a week, because the kidney is totally out, not functioning. Yeah? You cannot recover. Okay, clear?
Understood. Yeah, clear.
All right, okay. Sorry, I didn't get your question earlier, but I hope it's okay now, right? Okay, anything else, boys and girls?
Prof, I have a question.
Hmm.
Regarding the microscopic view of Bph.
Hmm.
Can you go to the what's the rounded pink?
What is this?
The thyroidization too, right?
Corpora Malaysia.
Corpora amylasia. Someone remembered. I taught this in general pathology, so you should
It's corpora
remember. I'm
amylasia.
sure it was taught to you earlier. Corpora amylasia is just concentric proteinaceous accumulation in this disease. Don't ask me why. They just produce protein so much that
It becomes like a solid inside.
it's very nice looking. Actually, it's diagnostic. It's very diagnostic. When we see this in cross section, usually it's associated with
Bph, yeah.
Corpora amylasia. Okay. Any other questions? Okay, can we call it a day?
Sure, doctor.
Okay, have a good weekend. I see you on Monday, right?